I'm Dr. Rahul Singh. People who don't know me, I'm a pediatric neurologist. I work at Guy's and St. Thomas's Hospital. So maybe I always ask parents, they know more than a clinician because they might have been to different meetings, and I know all of you have seen Nicole and follow up with her. So, but it's an interesting condition. I have got interest in this condition, and I've been given permission from all of my colleagues that I'm happy to collect information regarding that. So what is 4H syndrome? It's a rare genetic leukodystrophy. 4H stands for hypomyelination, hypogonadotrophic, hypogonadism, hypodontia. You don't need to have 4H for you to have 4H syndrome. You can have 3H, you can have 2H, or you can have without hypomyelination as well. So this is relatively a new gene. I think the first gene was found in 2009, and then onwards there is an expansion. So people are trying to understand these conditions better. So this is caused by mutation in POLR3 gene, and inheritance is autosomal recessive. So I thought it would be helpful when I met with the group last time and this time for them to give me a snapshot of what they feel, how can I help, instead of me going through all the genes and talking about the proteins and the function. So like they summarized all the features, what they have seen in their boys. We have 5 on our registry at the moment. Today I was told that there's 2 more, and there's 1 in London who is not on the registry because he's been following up. I don't know why he has not come on registry, because maybe we haven't got a genetic diagnosis for him, but clinically he fits into 4H syndrome. So we will have 8 kids, and can you see 2 out of 4 hypotonia. Hypotonia is common. All of them are requiring occupational therapy support. One has got hypogenesis of corpus callosum, then another one doesn't have hypogenesis of corpus callosum. And someone had cerebellar signs, cross-developmental delay, and what I see that there is a significant cerebellar dysfunction. So cerebellum is not only for your motor coordination. It coordinates your emotion as well, and it coordinates your learning as well. So people talk about limbic cerebellum, people talk about emotional side of effects of cerebellum, and lot of kids where we had, they get referred to us with, they fall more often. They were never able to run fast, and they couldn't catch a ball. Okay, they're hypermobile, bendy. Okay, you know, then entire thing, developmental coordination difficulties comes in picture. So you see the theme which is there with, and what has not been addressed that clearly is their neuropsychology profile, their behavioral profile, how it affects your cognition. Because even in kids with corpus callosal agenesis, so corpus callosum is an important part of our brain. It connects right side of brain to the left side of brain, okay? And the coordination happens very fast. If you have a small corpus callosum, everything becomes very slow. For your motor-wise or thinking-wise, everything takes a bit of time for it to grow. If someone has small corpus callosum, that's not, there are a lot of normal people with absent corpus callosum as well. So there is a professor in Sheffield who was scanned for a research study, and they found that his corpus callosum was missing. So if you call professor normal, then he is normal. But then there were other behavioral difficulties which was there. And so we need to address them for our population in UK, and whatever needs to be done, we will do it together. So all the inherited white matter disease team in UK, we will do it together. So clinical feature, you can see it ranges from ataxia, tremors, spasticity, coordination problem, So some of you, your kids have ataxia. I can clearly see their speech is a little bit cerebellar speech, and then they can write, but there's a little bit of tremor which is there. And MRI doesn't need to have hypomyelination. And if your MRI scan was done before you turn 2, and you have only one MRI scan, yes, clever MRI neuroradiologist can make a diagnosis of this thing, but in kids less than 2 years old, we ideally need 2 MRI scans to call it hypomyelination. So we don't know the rate of progression of myelination. And endocrine, so they can have delayed absent puberty, short stature. Not only that, there's a recent publication where they have found link with type 1 diabetes as well. There's a report of child with this mutation and having diabetes. I'm not saying it causes it, but these are the phenotype expansion. This is what happens with a new genetic condition. As time progresses, you start finding new symptoms. And you can have a natal teeth present or hypodontia or delayed dentition, any combination of teeth problem in a child with developmental delay, and some suggestion of less myelin on the brain scan, I would think about this condition. So other vision and speech problem, that is all multifactorial, not directly linked to this. So you know our body has chromosome, gene, and DNA. So chromosome is like your cookbook, all recipes there, right? Gene is one particular recipe, and DNA is the spelling in that recipe. So our DNA makes RNA, and that makes a protein. Protein is the dish you like, recipe, what you want to make. So here we have POLR1 DNA, which makes ribosomal RNA, and the protein is RNA polymerase 1. Then same with RNA polymerase 2 and RNA polymerase 3. So 3A, B, and then it is getting better. Every time I see there's a POL1 K, new mutation has come up. This is a hypomorphic gene. The less you have, the less protein you have. You can't not have RNA polymerase. If you don't have any RNA polymerase, they present very early in age and they don't survive. So everyone has RNA polymerase, but the way it works, these 3 enzymes are linked to each other. These 3 enzymes are linked to each other, so there are some unit which are common in RNA polymerase type 1 and type 2, some is common with type 3. So that's why it works, but we don't know why something causes cerebellar atrophy, why some mutations are associated with corpus callosal agenesis, why teeth problem, why skeletal problem, why face problem. So we are getting to know about these conditions. I'm not a geneticist. I wish James was here. He could have explained it a bit more better. So what we know so far is POLR3A. They're present early. They're more severe, and it is exactly proportional to the number of how much RNA polymerase you have. So POLR3B sometimes milder, and 1C and 3K rare, but it is broadening spectrum. So the list of all of them are autosomal recessive except POLR3B de novo, 1 case report there, but all autosomal recessive. I don't need to explain it to you what autosomal recessive is. And you see some with central hypomyelination, some with peripheral nerve demyelination, and variable clinical phenotype. So this was the recent case report with POLR3B, expanding phenotype, co-occurrence with type 1 diabetes. So I said not everyone needs to have all 4H. We are understanding imaging is good, but we need 2 points of imaging, at least in kids who are less than 2 years old, to call it hypomyelination. And how often do we need to do MRI scan? Do we need to monitor? All those things are questions which I ask myself. So severe onset, newborn baby, they don't survive. typical onset, toddler or childhood onset, and there have been report of adult onset, which is milder phenotype. They present more with spasticity in the leg and with some changes on the brain scan. So these are all the other phenotype which has been reported. Treacher-Collin-like syndrome, neonatal progeria. They look very old when there's a newborn babies. So they have very less amount of one of these RNA polymerase. So as told you, 4H, 3H. This was interesting. They can get severe chickenpox infection. I didn't know that till 4 or 5 years ago. Then recurrent shingles. Some parents complain, oh, so if I see someone, I will get their chickenpox antibodies checked, and if not, I will get the chickenpox vaccination done. Don't know why it happens, but that is something which alerts. And then the cognitive phenotype, we need to understand it better. So currently, as you know, no cure like there's no treatment to change the spelling mistake in your gene, but mostly it is supportive, and you need multidisciplinary care. What I see, the same thing with other white matter disease, patchy involvement of occupational therapist and physiotherapist, and endocrine monitoring is also patchy when they need hormone therapy, because hormones will affect your bone growth. It will affect the mineralization of bone. So hypomyelination is not a problem, but preventing them from things which are preventable, that should be our aim. Whenever gene therapy comes, we talk about it, but most important thing is what can we prevent them from getting? If they are at risk of having recurrent bad chickenpox, like one of you had the experience of bad chickenpox. So is there a role of this thing? These are the questions I need to ask people who have worked more, like I'm meeting Nicole next week, so I will ask. And regular dental intervention and myopia. Visual this thing, that is common as well. And one of our girls had a very special smart glasses. And I asked her, will she exchange it with me? She said, no, it's very cute. It's a Barbie glasses. I'm not going to exchange it with you. So keeping a good eye on myopia side of things, because if you become deeply myopic, you can develop retinal detachment. So regular eye follow-up, regular dental follow-up, someone is keeping an eye on the hormone profile, give the hormone when they need it, when they reach the puberty stage, if they're delayed, they need to get tested, all the puberty hormones and everything, because that might have implication on their general health and well-being. Okay, so I know that in sort of Phil Chop, I was there with the team. They have this myelin depository biobanking program. I got the protocol from them. It's getting a bit difficult for me to get it there. They were happy to help me set up things here. So let's see. And then Nicole is doing all those work, international genotype phenotype study. So they have developed a mouse model on POLR3A, and these are all in discussion. I don't think Yaya Foundation, I met with the team there, our LXTLC, we are supportive, we are seeing what we can do. I think 2028, realistically speaking, if there's something has to come, it might come. So it's rare, we don't know, we don't have the natural history data, so we have taken a step to get as much information as possible from our registry, and same problem with any other rare diseases, validated biomarkers and trial endpoints. So preclinical models have been established now, and these are all how you deliver the gene therapy and everything. That always remains a challenge. And for us as a NHS clinician, I wish we had a dedicated leukodystrophy center, and we could do all those things. We could happily do it, but the way system is at the moment, we can't. It drains you. There's so much of time. So in summary, think about what is preventable, how best we can support them, mobility, how best they can, how steady they can be. Do we need to work on their core muscles? We don't want them to fall. We want their bone strength to be good. Visual function should be good. They shouldn't be developing deep myopia and this thing. And so I will stop there. You all have my contact detail for our data manager, and I will seek proper consent from the people who are looking after you. But first thing will be to write about our cohort. We have got 7 or 8. That is my next 6 months job. Okay, so I will send you details of what data we need, what we have. We have discussed. Before this meeting, we had another talk with Lydia. So they know all those things. So, yeah. Yes.
Sorry, can I just ask you 2 questions? So, like, Josh hasn't had an MRI scan for about 3 years now. How often should we be asking for MRI scans?
So, normally in clinical world, we decide clinically. Anyone who needs MRI scan from our cohort, they will need general anesthesia. Now, the question we ask, is it justified to do it?
What it was is, obviously, we went to see Dr. Wolf in Amsterdam, and he said it lasts for 30 days on a stick, and I'm not technology minded, so when we got to Amsterdam, she couldn't access it, so we've never been able to show her our MRI scan for Josh, so we can't. It's sort of irrelevant to us keep going over there to see her when we've got nothing evidence-wise to give her, let's say. So could we request an MRI scan again off our hospital? And what would we do if they knocked us back? Because they're very reluctant to do it, let's say, so because he has to go under anaesthetic.
I didn't get it.
Two bits to that. Firstly, we can send your scans for you, so you don't need to do that, and that's not a stick for the last half an hour, last 30 minutes. That's not a problem. We swap scans internationally all the time. And I wouldn't rescan my patients either.
No, so every time they have repeat scan in Amsterdam, it costs them $1,000. So
Differently, so one of the I've worked with colleagues in Amsterdam. They have 2 scanners in the hospital, one of which is purely paid for on a research basis, and one of their scanners is a research scanner, and they lend it out to the hospital, but actually means that if they want to put scan like patients, they can always do it.
Yeah.
It's very expensive, and they do a different sequence, so they don't anaesthetize all of their patients. They do a fast T2. So we don't all do that in the UK. So I mean, for peripheral hospitals, they probably won't be able to do that scan. So they do lots of scans if they are a very research-driven centre. So it's not wrong that they do lots of scans if they do them without anaesthetic. But actually in the UK, we would need an anaesthetic. And if it's academia that they're learning, if we're going to put your child under risk with an anaesthetic, I think we're probably then actually, unless there's a clinical change, I wouldn't research.
Oh, I get that. Also, like the endocrine, is it? What sort of age should they be getting involved? Because we got told 10, 11, let's say, and Josh is 9, going on to 10 this year. So should we be sort of pushing for that, or
pushing for MRI scan? Endocrine. No, so I've shared my data manager's detail with you all. Send the information if you are not known to. If you were known to our center, you'd know that. Then we do the recommendation to your pediatrician that these things needs to be done. Okay. 2 of you were seen in London, so they had their test done there. So we can facilitate that. We can request it to. So the way it happens, if I get a referral for you, we are going to discuss it in our MDT. Then we outcome it, that these are the things we want to do, and then we send that to your pediatrician.
And how often should the community paediatrician be involved? Because we haven't seen our one for 18 months now, and he said every year, but it's like I have to ring up and make an appointment to him for him to see our son, rather than him forwarding to me saying, right, I want to see Josh. So for me, I don't mean it nasty, but I don't really want him involved because he's not very interested in him. And if you get me.
That's why writing about all of you and then giving a recommendation, this is the way we want things to be done for this group of kids. Yeah, then everyone will follow it. So it's not just with this condition that there are other conditions where community pediatricians engagement is minimal, but depending upon his needs, how much physiotherapy he needs, how much occupational therapy he needs. One thing I want to do, they understand their cognitive profile, get it assessed even if it is a baseline. So I might have some resources to get that done in our center. That's why I want to collect all of them together.